It's hard to get into the next 9 minutes the evolution of pediatric cataract surgery, so I may have to move through some of it. But basically, the historical review is we started off years and years ago with optical iridectomy, moved to needling, then aspiration, large wounds with intracapsular extraction. And then the big breakthrough came with automatic vitrectomy in the 80s. And then we borrowed, and this is, I think, where the big breakthrough came, is from adult phacoemulsification, small incision, micro-instruments, and the pharmacological treatments that we've done. I just don't have a pointer. So I thought this is a very interesting paper published by David Taylor and others in 1981 and 2001, Should we aggressively treat unilateral congenital cataracts? Because at the time, to me, the results of unilateral congenital cataract surgery were pretty poor, and these kids ended up needing contact lenses. When I started doing these first, I started putting implants in their eyes, but again, the visual outcomes were very poor. This was a big breakthrough, was in the two, Hubel and Wiesel, who got the Nobel Prize in '81 for the critical period of visual development. Now, we now think that, and some studies have suggested that the critical period of visual development is not the first 6 weeks, but it may be more than that, 8 weeks. And initially, whilst we did congenital cataracts, we did them very early on in the first 4 weeks, 3 weeks. We've, as you know, moved to about 6 weeks now, because we know from studies that by delaying surgery, we reduce the risk of glaucoma. The management of the anterior capsule is the first thing we come across. It's not like adults, and there are a number of approaches, either this Ken-Nischel approach of the push-pull technique. Most people, I think, use the vitrector to do it. For years, I've used the radiofrequency diathermic Clody system, which you can insert into the eye. It's very reproducible. We published studies on this, showing the results of this both in the anterior and posterior capsule. And then the other useful thing to have in your practice is the YAG laser system, the Micropter 3, which can come over the eye of the child and has a useful adjunct effect. Expensive, but very useful in this area. The posterior capsule is the next thing. When should it be preserved? In Ophthalmology 2002 suggested that less than 6 years, probably 4 years. Obviously, if you leave it intact in the first year of life, you can almost be setting 100% opacification. The use of vitrectomy, yes or no? Yes, vitrectomy in the first 4 years of life, the core vitrectomy. Otherwise, it forms a scaffold for reopacification. Always interested that if you take away the capsule in an adult, and accidentally or otherwise, you get increased risk of cystatic edema. We looked at this in children with Katrina Kerwin, and showed that we didn't get cystatic edema in these kids. The next problem is postoperative inflammation, fibrosis, capsular opacification, and the result of the capsule becoming opacified, and about many of them do in the first year of life. And again, this is the sort of scene you get with lots of adhesions, fibrosis, Elschnick's pearls, and so you end up in a pretty terrible situation, especially in the younger babies. And then the postoperative management obviously has to include topical steroids, systemic steroids, intracameral steroids, and you got to dilate the pupil. This is what we did in 2010, which was the single biggest breakthrough in my practice in reducing this postoperative inflammation. Use for intracameral triamcinolone at the time of surgery made a huge difference. Published this in the JCRS in 2010. Refractive management, as I said yesterday, aphakic specs are very useful and work very well in kids with bilateral aphakia. Intraocular lenses, controversial in the first year. Contact lenses. And then we have all the other agents, like using implants as a secondary in the case of the high myopia, the myopia that they get afterwards. Hydrogel lenses have made a huge breakthrough. These are the new silicone hydrogel lenses. And they now, I think, in my practice, I no longer put implants. In the first year, I use these contact lenses, which have been a major breakthrough. This is a study, as you know, the IATS study, published initially in I think 2014, showing that where they compared contact lens and IL group, showing that the IOL group had about a 72% needed additional surgery. The rate of glaucoma was the same in both groups of patients. You had this huge myopic shift that occurs in unilateral cataracts, and this is where implants come in. And I recently reviewed the longer-term follow-up of their study, and they have explanted a number of these implants, and they say quite successfully without any complications. Obviously, the visual outcomes in this group are still poor, although they've dramatically improved. And then we looked at this ourselves, glaucoma in a aphakic and pseudophakic group. And again, we found that there was no difference in the two groups, whether you put an implant in or not. Just some new things that have emerged. This is known as the Zepto. It's been approved by in America. You put this little instrument into the eye of the child, and it opens up, and it's driven by a motor. And as electrical impulse comes in, it sticks to the capsule. And it's the alternative now to the Cloti system. I'm not sure how many people are using it, but it's certainly a potentially very useful new technique for doing anterior capsulorhexis, which is one of the biggest problems in these kids. You've got to get that right. If you get that right, everything else follows on almost. It's like adult cataract surgery. If you get the capsulorhexis wrong, you're on the back foot from there in. Huge amount of pharmacological agents, intracameral antibiotics. As you know, the European trial showed that this was the way to go in adult cataract surgery. We've now translated into children using APROC at the end of surgery. As I've just shown you, in my practice, intracameral preservative-free triamcinolone has made a huge difference. 4 milligrams in 0.1 of a ml at the end of surgery. I haven't seen any of the usual doomsday stuff like glaucoma. In fact, it works really well. And of course, the new drug delivery systems are now in vogue, and particularly the nanotechnology, where you can deliver these systems safely and effectively with less side effects. And these can be given in contact lenses, or you can put a plug into the punctum, and these slowly deliver these antibiotics and steroids into the eye. And this is something going to be very new and going to be innovative. This is a study in Nature, and you may remember in 2016, it came out of San Diego, a heavy Chinese involvement in the study. And this was known as lens regeneration using endogenous stem cells, and it was supposed to be the great new hope. And the idea of this is that you just did took the capsule away, left the periphery of the capsule intact, and removed all the lens matter. And the idea is that the peripheral lens cells would regenerate into a clear lens over the next 4 or 5 months after the surgery. The problem here is we haven't seen anything subsequently, at least I haven't anyway, and no subsequent publication has emerged from this. And so I'm not sure where this lies at the moment. I don't think it has gained any traction. So what can we say today? The outcome of congenital cataract surgery has greatly improved with a number of these factors. Obviously, the surgical technique, all the phaco, as I've said, small incision, bimanual, the use of pharmacological agents like Helon, Viscoat, and then, of course, the use of these drugs, the intracameral steroids, intracameral antibiotics, the nanotechnology where you can deliver these drugs safely and effectively, which is going to be the big new, I think, area of surgery. And you can deliver these by means of by punctum plugs and so on, by contact lenses. The huge improvement in contact lens technology, I think that's been a major advance. So that means that in the first 6 months anyway, I've moved away from using intraocular lenses, and then maybe after that one can put a lens in. And because the contacts can be left in for 3 months, they're safe, effective, and they have much fewer side effects. And of course, you don't have the growth problems that you do with intraocular lenses. And then, of course, as we spoke yesterday, the refractive management of these kids, you can go back in and you can put implants in, you can laser the cornea. All of these are potential options and now becoming safer and effective, and no reason why one can't avail of them. But the biggest problem, obviously, at the end of all of this is the amblyopia management, because that will determine what kind of a visual outcome you'll get, particularly in unilateral congenital cataracts. I think the bilateral cataracts, pretty straightforward. The problem is the unilateral ones and the visual outcome in those group of patients. So thank you very much.